Just to make sure you're in the right room, we're going to talk about treating rare genetic epilepsies. And if you're asking or wondering why they picked the old person in the room to talk about the new diseases, don't ask me as well. But anyhow, my name is Dr. Jim Wheless. So I was still am, I guess, but a pharmacist by training that then went into medical school, obviously, and then pediatric neurology. And so I've been involved in new treatment trials over the years. Traditionally, those have been what we think of as kind of standard medications, if you will, with my background. But we've switched now for several years into looking at kind of targeted therapies for genetically based epilepsies, which as a group, individually they're rare, but as a group not so rare as we once thought. So let me try and work you through that. It's a challenging topic because genetics is really complicated, so I'll try and do it in a way that we all can track me, including me, as well. But so it makes sense at the end of this when we get done with this, hopefully. So let me just start with the obvious things, which is before we can treat an epilepsy that has a genetic cause, we have to diagnose the genetic cause, right? That would probably seem obvious, but we have to know what we're treating other than just the epilepsy, because once we start talking about treating a genetically based epilepsy, we're not just treating a symptom anymore. So the symptom, if you will, is the seizure. We're saying what caused it in the brain to begin with, and I want to treat that. So I actually want to treat the disease, if you will. The equivalent would be, if I had pneumonia, I could say, okay, we could treat my fever as a symptom just by putting me on Tylenol all the time, but eventually I might say, can we just give me an antibiotic and treat what's causing the symptom to begin with and get rid of this problem? So that's our goal. Let me just quickly, I don't want to make everyone here a geneticist. Actually, no one here wants to be a geneticist probably, but let me just walk you through some of the terminology, because this is the challenge we get into. Anytime we get into a new treatment area, we all have to know kind of the right wording too, so we can make sense of it. So I'll remind you, genetics, only had its start in 1800, so not that long ago. But if you zoom a lot quicker ahead in my timeline, what you really see is that when President Clinton was in office, which probably seems like ages ago to many of us now, and then was finished under President Bush, they had the funding. So anybody who was employed then and paying taxes, thank you very much, that helped pay for this, your government at work. But we paid to sequence the entire human genetic material. So we did that by looking at genetic makeup of kind of lots of normal individuals and saying, what is the exact code? How do you make a human? So if you want to think of it as an instruction book, if you will, and we need to know everything that goes into it. So that's pretty recent. At the time that was done, to do that, it cost $100 million. That's how much me and you paid if you were working back then. Nowadays, even if you paid cash, you can probably get it done for $2,000. So that's what's really changed the landscape, because if it still cost $100 million, guess how many of us would be doing that in routine clinical care? Yeah, this would be a very short talk, right? We'd be all having a snack now. So it's really changed dramatically, and a lot of this has been driven by dramatic changes in computer technology, and that's what will continue to push this. And I know for many of us, the words artificial intelligence are not, they're almost like four-letter words, but they're not. But you have to stop thinking it that way, because we all use it every day, and there are some good uses, so I'm just going to mention those. We won't mention any of the bad ones, okay, as well. So let me remind you the terms I'm going to talk about. So every one of us has a normal karyotype, hopefully, but it's 46 chromosomes. So if you want to think of this, the analogy I often give my families, think of this as like a book. If we each came with an instruction book of how to build a human being from scratch, think of one that has 46 chapters, okay? When we look at the karyotype, that's all we know is that, okay, are all the chapters there? Do they have the number of pages? And are there 46? That's all we know. We don't know what's in them. When we get down to chromosome microanalysis, we're saying, okay, not only are they all there, but are there any teeny little pieces missing or not? So like, is one chapter, if you will. So a reasonable sized chunk. Then we moved on from that to epilepsy panels, where we say, in that entire book, there are nowadays, the average panel screens for about 300 genes. So we're looking for 300 kind of spots that if they go wrong, make you more prone to epilepsy. And we're just looking at those. We're not looking at the rest of the book, if you will. We're just trying to find, are those 300 there or not? When we get the whole exome sequencing, we're saying, what are all the important words in the book? And there's 22,000 of those, and we're looking at now 22,000 important. words in the book, okay? And that's what makes most of the proteins, so most of what builds our brain. And then we finally get the whole genome sequencing, which is what cost $100 million, but no longer does. We're saying we want to know every letter, everything in the book. We want to know if anything's missing, okay? Believe it or not, even knowing all that doesn't tell us everything because it's just looking at every letter. So to be simple, if I said C spot run was in the book and you said it's all there, but in the book it was C run spot, the computer would say it's all there. But it's still not all there normally. So even with that, yes, can we have a genetic cause and not find it? Yes. Okay, and people are looking at how we target those now as well. So that'll be the next thing to hit down the road, okay? So let me maybe bring this home with a patient, and I'm going to try and weave one in through here and talk, because we get to treatment, you'll see why, but it'll make sense because we have to start talking treatment with the ones that are closest to treatment. Just almost 1-year-old, maybe not an uncommon story for some folks in the room, but had a febrile seizure, then a prolonged febrile seizure. Got appropriate evaluation, EEG, MRI, placed on medication, but kept having prolonged convulsive seizures. And in the modern era, when you don't have a reason, as in this case, that brings up the obvious question, which is, do they have a genetic cause? And we know that in the first couple years of life, if you start epilepsy then, that actually genetic cause is one of the more common reasons. So the question that I face as a physician, that families sometimes get involved with is, okay, if we think that could be there, what tests do we do? Because I just mentioned a lot of tests, or do we just sit tight and say, well, wow, let's make sure that there's that it progresses in a logical manner, the epilepsy, and if it does, I could say, aha, I know what that is, and do I need a genetic test? So keep that in mind as we kind of walk through this. So what I'm showing you is kind of how we used to approach this. We'd have a patient like our child that had unexplained epilepsy. We'd probably treat them with an anti-seizure medication, ASM, that we call in the modern era. If that worked, great. If it didn't, we might slowly down the road at some point get into genetic testing. We'd have to figure out which tests to do. In the modern era, I think what we've shifted to is if we have a patient who doesn't have explained epilepsy, that we should be doing the genetic testing up front. And the rationale behind that is because that will actually give us an answer up front, which will guide treatment. That's the short version. I'll tell you a little bit more, but that's the rationale for doing it. And this is kind of the cartoon version of why that's important, because once we know they have epilepsy, a patient has epilepsy, if we can figure out the underlying cause or etiology and it's genetic, then we can appropriately manage them, even in the modern era, because we know there are some treatments that work better depending on what the genetic etiology is. And nowadays, this is actually kind of a position statement in our national organizations as physicians. So that's kind of been approved. And you see it here that patients with unexplained epilepsy should have genetic testing done. The challenge that I get for many folks is, okay, everybody says you should have that done. It's just kind of figuring out the payment source for that. It's gotten better and better. Years ago, it used to be almost none of these were covered by insurance, state-based care, TRICARE, you name it, whatever you had. In the modern world, many more of these are being covered by insurance companies, and many of them even being covered by state-based Medicaid programs, more and more, and that's still progressing actually fairly rapidly. Most states, you almost have to keep up with this in your own state, because year by year there are legislative changes being passed for funding to cover genetic testing, not just in epilepsy that we care about, but in other areas as well too. So this is clearly at the forefront, and people have finally understood that the ability to get this testing, it shouldn't be harder to do this than it should be to get an MRI or something like that, because actually they cost about the same. So it should be doable. And we know with some of these tests nowadays which are the better yields. So the one that we call the whole exome sequencing probably is where we would like to start in most patients. This basically gives you every gene, the 22,000 that are responsible for the proteins, which are the building blocks in our body. So it really gives you a very detailed landscape of the picture. And why is this important in neurology and in epilepsy. If you look here, and this is a bit complicated, but focused on a couple of these bubbles, if you will. So you see that it goes kind of percent yield, so how likely are you to have an answer? And you can see that for epilepsy and for folks with either autism or developmental delay or mental impairment, it's much higher, our yield. So those are actually some of our higher yield groups where genetic testing is going to give us an answer and other testing won't. So we know that, which is also kind of pushing this a little bit as well. And I'll talk about some of these in more detail and kind of how it helps us. But for example, if we know someone has Dravet syndrome, which is the bottom here in the green, sorry, started at the bottom of the slide, we know there are certain medications that will make their seizures worse. Obviously, we don't want to use those. We avoid those. I'm going to talk about kind of genetically based therapies in a minute that may help them be better. And you guys have probably seen there's folks even in the exhibit hall for those. If we know someone has what's called GLUT1 deficiency, we know there's a genetic marker for that. And actually, those patients just need to change their diet and they're seizure-free. They don't even need medicine. So it's like kind of one of the best things to find, if you will, from an epilepsy standpoint. So just to give you a couple dramatic examples of how much knowing the genetics can really modify where we go with therapy. And obviously, early diagnosis is important. And why do we say that? So think about this. Many of us as parents wish our children came with instruction manuals, so the genetic book, like I talked about, not only just how they're put together, but like how to actually deal with them. But our DNA is the instruction manual. So I always kiddingly tell my patients, if you gave me, for example, like a pile of bricks and some mortar already made up and said, make a wall for me over there. I could do it. You might not say like, wow, this looks professional, but I could kind of put it together. But if you come by, and I've only been at this 10 minutes and maybe have done a little bit and said, oh, clearly we hired the wrong person, let's go get somebody who does this professionally, and they could kind of maybe fix mine and finish it off and look good and be like, okay, no foul, no harm, you have your pretty wall, right? But if you let enough time go by that I'm almost done, and then you say, oh, let's try and fix it, it's really a problem, right? So think of the child's brain that way as well too, right? Because their brain is developing. A lot of brain growth, actually over 90%, is in the first 2 to 3 years of life. So if we have a genetic problem that causes epilepsy, ideally, if it affects how that brain is being made, the structure, we'd like to know about it as early as we can if we have a treatment so we can fix it as early as we can, right? What we don't know is if that same child is now 16 or 18 or 20 and we intervene later, does that same genetic therapy, what does it do? We know it may not do as much as a very young, but how much it will do, we're not sure of yet. So that's going to be one that we're going to be all living with for a while. Unfortunately, a lot of the trials that are being done don't answer that question. So we may not even know that when the products are approved, is how much they'll do. So you guys will be kind of living with that same frustration that we have. But timing is important. We have tons of genes now that we can find with our genetic panels that have specific actions. And I've just highlighted a few here, but there are tons of those. We were actually part of a group that looked years ago at kind of what difference did it make, because insurers had questions. And so we said, what difference does it make if we find one? And you can see the difference it made. There were a lot of changes in medical management once we knew what the genetic basis was. Some of those were taking away medicines, some were changing meds, some were even doing other things like, oh, this may help your child sleep, this may help their behavior. So they weren't even all epilepsy related. Go ahead. Previous slide request, sure, it's repeats early. Whoops, we went the wrong way. Well, maybe, there we go. So we know, and we've got really good data that actually it does make a difference if we can get it. And I would say, these are just a few of the points. You may have some of your own that if you have a genetically based diagnosis in your family, but it can help us guide treatment. That's the obvious one. We can stop doing needless tests, right? Because if I know, this is the genetic etiology that's driving this person's seizures, then I quit doing MRIs every couple of years, unless there's a reason, like in tuberous sclerosis, it's genetic, but I still have to do MRIs for surveillance. But with other ones I know, no, those are never going to change. So I can stop, putting your child to sleep, your loved one to sleep, quit doing those. So it can help me kind of avoid unnecessary tests, if you will. I think there's a lot to be said by finally having an answer of why your loved one has epilepsy. Universally, every family we give that information to, even if it's something we don't have a current treatment for, likes it because they like knowing that, oh, now at least I know why, my loved one has this. And if it changes treatment, great. If it doesn't change treatment today, maybe it will down the road as we get smarter about that. But then also for many of the moms, they know that, oh, this wasn't because I did this or that when I was pregnant. I'm not the guilty one anymore, which is universally what people think. It's because of this. And, so I think it's people like to know, as you can see from a lot of the lay organizations here, the upside of social media in years gone by, people couldn't touch base with other families that had the same problem. Nowadays, almost every one of these genes have a social media group you can find online. You realize you're not the only one out there. You can find folks with a younger child, older child. You can realize like, oh, this may give me an idea what I'm in for. Whether you want to know or not, it's your question. You have to do, but at least gives you that information as well also. Obviously, if you have other children, and if they're females, it may help kind of say when they grow up, is this something they'll go on give to their kids or not give to their kids? So it can help with kind of what we call reproductive counseling, even if the parents are not planning on having more children themselves. And for clinical trials, it's huge. Most of our gene-based therapies, as you'll see, require a specific genetic diagnosis. So if you don't have that, you don't kind of track those either, and you're not aware that they're going on as well. So if we go back to our patient that I mentioned, his panel was done at the time. He was positive for SCN1A and had Dravet syndrome. The other person I want to give a shout out to, and then we're going to quickly transition to treatment, is our genetic counselors, because a lot of our families, just like many of your physicians, are not genetic experts. We're getting there more and more every day. But kind of what does that mean? How did they get it? Do I have to worry about other siblings? What does it mean for other family members that once I tell them my child has this, they're like, whoa, does that run in our family? We didn't know that. So genetic counselors are experts on this. They're also experts in helping us kind of when we think you need testing, figure out like how do we get that done? Where's the right lab if we need follow-up? So they're key people that kind of work with us to sort some of these things out. The challenge that we had historically is once we made the diagnosis and we said, what do we do for treatment, is we knew the gene, but how to say what the gene being kind of off did to your child's brain or their body, we didn't know. And the only way we could do that was very experimentally. So what did we have to do? We had to like put it in an animal that you could study in the lab. You had to then say, okay, if we put this abnormal gene in, do they have seizures? What happens to them? How does it affect their brain function? And then assume that that was the same thing that happened in humans. So one, this was really experimental. As you might guess, it could take years to even walk through this for one kind of person and one gene. So it wasn't really practical to get to a patient level. So what's changed with this in the modern era? And I just want to give you a hint of kind of a couple of the pieces that are ongoing. This is not answering the whole thing, but just to give you an idea. So if we go to our SCN1A patient, for example, there's a really nice group in Scotland that's done some great work putting together a computerized model that's very simple. All I do is put in that child's age of first seizure. Of all the SCN1A gene kind of defects that can cause you to have Dravet, and there's over 1,200 of those, I can put in exactly which one my patient has. So if theirs is number 567, and it'll tell me, is this patient have Dravet, or is it something like Dravet or what? It gives you a predictive value. So it's using kind of artificial intelligence in a good way, if you will, to help us sort that out. And these databases are getting built and more robust. So that's maybe a more straightforward one. Let's look at one that's a lot more challenging. So what if you have SCN2A? So this is where our genetics gets tricky. If you have SCN2A and you have what we call gain of function, so it's working too well, you show up as a newborn with horrible seizures. Multiple daily seizures, 10, 20, 50, 100 a day. You may never leave the neonatal ICU because you're having so many seizures. But if you have what we call SCN2A loss of function, it's not working as well as it should, you may not have seizures at all, and you may just show up later in life with autism. But it's the same gene. It's just whether it's overactive or underactive. So how the heck would I know that? Because when I get back a gene test, it just says there's a change in my SCN2A. It doesn't tell me is it hyperactive or underactive. So people have looked at using artificial intelligence because, again, you can put the gene model in, you can create a 3D reconstruction of what that pore looks like in the brain and say, is it a gain of function or loss of function? And this is an example of a loss of function one based on a kind of computerized algorithm using that patient's specific thing. So we didn't require animal data, anything. This could be done in a couple of days, just to give you an idea. So this is using, you know, computer technology, but to really help us figure out some of the gene stuff. And then for those of you who really keep up with it, if you want to know how does a gene exactly affect the protein, last year, Google, using their computers and working with bioscientists and physicists, actually developed a computer program. And this won the Nobel Prize in Medicine this year and the Lasker Prize in Medicine last year, because it predicts, you just tell it the gene, and it predicts 100% if the protein's normal or not. And remember, the protein is what drives the instructions to, are you building the brain or not? So this stuff is really there and happening. It's not quite at this level to like real medical practice. I can't do this for one of my individual patients yet, but it'll be there soon. Because once Google owns it, you know they're going to try and figure out how to sell it, right? I mean, come on. It'll be there. So that'll get there. All right, so let's switch gears now and go to treatment. So if you were devising treatment, where would you start? Well, if you were selling cars, where would you start? You'd start with, okay, what car sells the most, right? If I have something for cars. So it's not any different with genes. If we look at lots of patients with genetic epilepsy, this is over 25,000 people in a database, and you look at, okay, what's the most common? And you can see this doesn't go through all the gene causes, but I ran out of room on the slide, so you get down to pretty rare ones. You can see that at the top, you know, by a long shot is SCN1A. It's just the most common genetically based cause of epilepsy we have out there. So if you're ever on Family Feud and the category is genetically based epilepsies, remember SCN1A, hit the buzzer, okay? You'll win, okay? But this gives you an idea if you're wondering, like, well, why are there companies and trials going on for some and not the other? Well, this is why, to be candid, because these are very expensive, and so they're going to target the ones that, one, it makes sense for, because you can develop a trial, and two, there's enough people out there to say, let's see if we can really test it, see if it works. Doesn't mean the other ones are not important, and they won't get there, but they will also benefit from the technology being developed for the more kind of common ones, if you will, because the same technology will be used, it'll just be modified for the other genetic problems. So let me walk you throue Dravet, and where, just to give you an idea of how quickly this is going on in the genetically based therapies. So keep in mind, Dravet syndrome, we didn't know the gene until 2001. So that's pretty recent. It's the same millennium, right, that we're in currently. So we knew that. By 15 years later, in 2016, there was an animal model that said, you know what, this is not only the gene, we understand how it, goes, why it's not working properly, why it causes epilepsy. We had traditional medicines approved by 2018, and we had genetically based therapies. We started in trials 4 years ago for this. So if you think about it, to go from having a gene to genetically based therapies in 19 years may seem like a long time, but it's actually pretty quick in the modern world for this. And it will go even quicker with other ones, and I'll show you some of those now that kind of this, the concept has been proven, if you will. So Dravet, some of you may know, very devastating childhood epilepsy. I don't want to spend a lot of time on that, but it's due to this gene mutation. Very drug-resistant epilepsy, but like a lot of epilepsies, it's just not the epilepsy, right? It's everything else. It's the behavior, the developmental delay, the sleep problems, the feeding problems. I mean, you name it. It's not just the epilepsy, right? That's just the one that gets attention. And like a lot of our genetic epilepsies, unfortunately, these have a high mortality. I mean, it affects enough body areas that, unfortunately, this is a horrible thing to have, right, as well. And we know that this is the challenge, because remember I said if we're going to start these while the brain is developing, we want to diagnose them as soon as we can. Well, these kids are all normal at birth, and they're often normal till they're 7, 8, 9 months old. They're cute as can be. So you would never know that anything's going on, right? So you can't say, oh, we can start treating at birth. Well, not really, because we don't know who they are. And then they start with febrile seizures. Then it's not till they're older that it really progresses. So let me show you the cause of this and kind of the strategy for treating it genetically, because I want to show you a different one that has a very different strategy, just to give you an idea that this, kind of the different ways this can play out. So this is what happens in Dravet syndrome. So in me and you, if you see at the very top, we would have 2 normal copies of the SCN1A gene. So they'd both be green, if you will, because they're normal, they're doing what they're supposed to be doing. In someone with Dravet syndrome, they have 1 normal copy and 1 copy that's not normal, right? So they only have half of what they're supposed to have. And that gene is supposed to give instructions that if you follow this all the way down, end up in the blue. I thought I had a pointer here. Anyhow, you can see the blue. That's the protein. So think of this, if I have two genes, they're each supposed to make a protein that the brain has to have to function normally, and I only have one, I'm getting 50% or half of that protein, I'm not getting 100%, right? So believe it or not, in some areas of our body, if we have only 50% of the protein, we have enough kind of flexibility with function that we do fine. We don't need it. It's kind of like in this room. If half the light bulbs went out, we'd probably be okay, right? But if they all go out, it'd be different. So we have more kind of latitude. With this, you don't. You either have to have 100% or you're in trouble, right? You're going to have seizures and other problems. So we need that 100%. So if you look at the one on the red side, you say, okay, well, could we just fix the gene that's not working? That one that's supposed to be making 50% that's not. Well, that's the problem, because that gene, I already said, has over 1,200 ways it cannot work properly. So we can't have 1,200 different therapies and try and figure those out, right? So that was the initial thought, but people said, okay, that's never going to work. That's just unrealistic. So then other people realized, wait a minute, this one good gene, as you can see, it goes down to one protein, but it actually could potentially make two. It's just that the body has this reserve where it only makes one and then kind of discards the extra it makes, if you will. So someone had the brilliant thought. They said, well, why don't we know this good one's working? Why don't we just basically make it work more? So let's make it work more. So think of this, as I always tell folks, think like you had a factory and you had one shift and they were working away, everything was made properly, but you need to double production because you're only doing 50% of what the market would like you to make. You need to get up to 100%. Well, if it's a factory, you could just add another shift, right? If you had the employees, you say, okay, we'll just do 2 8-hour shifts, fine. We own the building. So that was a simple idea, is how do we make this gene basically double its output and do it? So the idea that people came up with was tango. And usually when I say that, everybody starts to get kind of in a dance mood and we just need music and we'd be good, right? But tango in this case, whoops, if I can get it to go, it didn't go, did it? Okay, tango in this case is targeted augmentation of nuclear gene output. And now you know why it's called tango, right? Because it's basically a long-winded way to say all we're trying to do is get that good copy to double its output. And can we convince it to do it? And can we convince it to do it by injecting it what's called an ASO? So that's where you hear that terminology, the tango ASO, that we're basically saying, okay, we want our good copy to make double what it's making before, and we're going to inject something into the person's body to basically tell that to do that, all right, with the idea that if we ratchet up their SCN1A, we can improve their symptoms. So I know what you're saying. You're going, wow, that seems like a really good fairy tale. Does that actually work? So this is why we have mice, in case you're wondering, because we can pick on them. So you can do a mouse model of Dravet, so you can basically have a mouse that's missing one of its SCN1A genes, and you can say, okay, if they're missing one, you can see, if you look on the right side, that line that goes down to the right off that graph, most mouse with Dravet, they don't survive to adulthood. They have an incredibly high mortality rate. But if you look at the line at the top, the mice that were given this therapy, which was the proof of concept, all of them but one survived. So it seemed to dramatically change and do what it was supposed to be doing. That launched the human studies. There's a lot more obviously done before it jumped to humans, but safety, other stuff. But that's where the idea came from, move on to humans. There were a couple of studies done. For those of you who may be a little bit squeamish, I was going to demonstrate in the next slide. I'll give you a fair warning. It's given intrathecally, which is just kind of similar to how if you are a female and had an epidural for childbirth, you understand the concept, but kind of like how we do an LP. So how do we do intrathecal medicine for ASO? So there's a needle that's placed in the spinal canal and the spinal fluid. We drain off a little bit of fluid, and as you can see, we inject the ASO directly into the spinal fluid, and we have to inject it there because it has to bathe the brain to get into the brain. We can't take it by mouth, it won't get to the brain. So it has to be given that route. Okay, so that's done. It varies, but probably the most common is about every 3 to 4 months for that technique, and we'll come back to why that's important in a minute. And then when we did that, as you can see, with this ASO, now brand name Zilvernuersen, that's Stoke therapy, and Stoke is here. As well, you can see the seizure improvements, and the green line is probably the best one, looking at kind of different doses, and that's, you can argue, a better dose because going down is better seizure reduction. It did what it was supposed to. Those were folks that were on their standard medicine and got this on top and had dramatic improvement. But beyond that, they also had improvements in other areas. And I think this is probably as important, is that they showed improvements in other areas that families care about, like communication was a huge one. Just being able to, like, ask their child, like, does that hurt, and get a response instead of just like, okay, they're looking at it like, I don't even know what you're talking about. Or are you hungry, or just basic stuff, but that just ability to communicate with a family as well. And we saw other changes too. This is one I'm going to show you next. It's a patient of mine that if it shows here, let's see if I can get this to work. Yeah, maybe. Here we go. He felt so good. This is 5 days after one of his treatments. No problem dancing in class as well. So he had other benefits beyond just the seizures and the other stuff as well. All right, so that's one approach that was taken, is to say, can we do that? The other approach that you'll hear about, and again, there's folks in the exhibit all here from other therapies, is what's called AAV therapy or AAV9 therapy. So what this therapy does is it says, okay, we know when people get infections by viruses, and the recent one, COVID, for example, that those can go to many organs of the body, including the brain. So we know that they can get there. What if we basically, the virus comes in a shell, if you will, and they let me borrow one. They have these in the exhibit hall. The shell looks like this, but it's a lot smaller. And what if we could take that same shell and empty out the virus, if you will, put in it the thing that tells the SCN1A, work harder, we need more SCN1A protein. That shell is still taken up into the brain, just like the virus would be, and it gets into the brain. That's what this is basically showing, is that we give that, again, it's in the spinal fluid, so it's given into the fluid, it's uptaken into the brain cells and upregulates their production of SCN1A. This one works a little bit different. Remember the other one I said was kind of like almost like you're kind of doubling the shift. This one is almost like, okay, it's working upstream and it's just basically delivering double the goods, if you will, to the factory. And then all of a sudden you say, oh, we've got to keep up because now we're getting twice as many trucks delivering supplies to us. We just need to add the employees, so it's upstream. So it works differently. The other key difference is when this one's given, it's permanent because it upregulates that upstream. It's like those trucks just keep coming, so they're not stopping. Whereas the other one, you could say, okay, we have that shift there. Someone called in sick, so we didn't have it this week, whatever. So the ASO therapies, we usually have to repeat. They don't stay permanent. This one is, as we sit here today, permanent. Now, when I say permanent, it's because when we give it to mice and look in the mouse model, if you give it to mice that are kind of early in their life, it lasts their whole life. So anybody have any idea the average lifespan for a mouse? I know it doesn't seem like this if you have mice in your house or anywhere. It's about 60-some days. So and that translates to their whole life. So in the mouse, it lasts that long. In the humans, we think it will last a long time, but we don't know yet. Is that 60, 70, 80 years? Because we've just started doing this. And in humans, the treatments that are out there that use this type of therapy are just a few years old. So, we know we can get 10 years now, but as we get 15, 20, we'll know more as time goes on. But it's a lot longer. It's not every 3 or 4 months is the bottom line. It's years and years. It's a lot different. And again, we can look at mouse models and they kind of prove the concept. They live longer. They don't have fever-induced seizures. So this is the fever-induced seizures that a lot of these Dravet patients have. They stop having after treatment, so they do much better than we would think. All right, so let me switch gears now and show you, that talks about like if you have an enzyme that's not working as well as it should, so what we call loss of function, how do we get it back to normal? Let me show you kind of how challenging this can be, because let me show you a different condition and how this was tackled. So this is another infant that started with seizures early in life, totally normal, then started with tons of seizures, 70 seizures over a weekend. Lots of seizures, right? Really a normal MRI, nothing that stood out kind of on the exam, and a gene panel was sent. Long and short of it is this female had what we call PCDH19 mutation. And this is an interesting gene problem because this one showed us that, we have to really think about how we treat these. So why do I say that? Because me and you normally have a PCDH gene, but it's only on the X chromosome. So again, take you back to regular biology. So males have 2 X's. So that means I have 2 copies, if I'm normal, of that gene, and it works. Females only have 1, XY. They're okay. So why do females that are missing one have one? You know, so that the challenge here is you have to think about that. If you're missing it, if you have none, you have the disease. But if you have the, you know, a good copy or two good copies, you don't. So and if you have none, you don't have it. So the targeting here is to say, let's attack, you know, the gene itself and basically get rid of it. So instead of trying to enhance its function, we're basically saying, oh, in the females that have this, we're going to knock out what little gene function they have because you can get by without this. And if it's there, you actually have problems. So it's almost backwards. It's almost like, you know, if I was talking to you in Spanish and you just understood English, it'd be a problem. But if I wasn't talking in Spanish, you wouldn't be confused because there'd be no language problem. And if we're all talking the same language, we're fine. So here we're better off kind of getting rid of the abnormal gene rather than trying to improve it. So this is a very different approach. And we have to kind of tailor these genetically based approaches to each of the ways, basically, if you will, that they cause epilepsy. So this is why we really have to understand why they cause it to begin with, so we can kind of tailor our approaches, because they'll be different depending on the cause. So I showed you this before. I'm just going to come back to remind you that our approach has shifted to kind of making the diagnosis first, because if we don't do that, we can't treat them as well. So the key is very precise genetic testing. The genetic testing is getting better and better. It will continue to improve, so that'll get better. So for those of you who had testing and said, gosh, you know, they can't find anything, but they're suspicious, I would say just hang in there. Our genetics folks relook at folks every couple of years because the testing is moving that quick, and say, like, is it to the point yet or not yet that we need to do that? There are a lot of genetically based therapies that are either about to be on the market or will be there soon. In the field of epilepsy, and across neurology there are, but there are several in epilepsy. So I always tell my patients, if you have your genetic testing and you know what it is, I would just Google it every year or two, because there's so much going on with testing that something is going to pop up at some point, you know, if you know that. And remember, not all the genetic testing is the same. So for Dravet's, we could be at a point down the road, for example, where we say, gosh, we have an ASO therapy, but that's every 4 months. You have to come to the hospital, get sedated, get injected. An AAV9 that may be one therapy, and I'm done, but there are different. But with the ASOs, the advantage are, since they go away over 4 months, if I have any problem, it's going to go away. It's going to be temporary. If I do the AAV9, if I have any problem, that's permanent. And so what do we understand about those, and making decisions with your doctors and kind of what's going on? I think as we get more information, obviously, that discussion's easier to have with families, and we know more about those. But keep in mind, they're not all exactly the same. Most of them are still used with traditional drug therapy, although for many of our patients, they get by with less drug therapy, which is good. They're brighter, they're more alert as well. And remember, we talked about kind of the age of treatment may influence their response, because what we're also understanding is there are some genetically based epilepsies that alter at a very small level brain structure. And if I treat those later, we've already got structure that's been built that I may not be able to change at all. But there are other genetic epilepsies that don't affect structure. They just affect how it works. So those we may be able to treat well up into adolescent adult and recover a lot of function. So they're not all the same. They're going to be very different in how they respond and how much to, quote unquote, expect from our genetically based therapies. And that we'll know more of as we get further along too, which ones are really, you know, heavily weighted to structure, and I've got to treat really early for my best response. And yes, I may get some response later, but it may not be as clear what it is. And which ones can I treat at any point and still get a good response? We don't, you know, that will become more clear as we get more information as well. And then the final one I would say is the FDA is still struggling with all these genetically based therapies, to be candid. They're used to traditional medicine. They're not used to actually treating the cause. They're used to treating the symptom, the epilepsy. They are really struggling with these as well. Work with your family organizations. You have to impress upon the FDA how devastating these are and how tired you are of them putzing along and not moving therapies forward that can help your loved ones. And if you don't do that, it won't happen. The FDA listens to families. They do not listen to doctors. You've got to do that. It's work, but if you don't do it, it's going to slow the progress down for all of these. I can guarantee you that. All right, I'm going to stop there. I appreciate your attention. Remember, the brain is where you live, and I'm happy to answer questions. Thanks. Let me get him, and then I'll come back to you. Go ahead.
Are there already tests or actually test results for the getting rid of approach, like how for tango, or is it still a planning?
No, so I'll repeat questions. I don't know if everybody can hear them, but yeah. So for the epilepsies so we're still learning a lot of to answer. The question was like for some of these where we need to they're low function of the gene and we need to enhance the function. For some of them, we just need to kind of get the bad gene out of the way, if you will, so the brain can work normally. Those therapies are not far off. There's one of those that hopefully within a couple of years will be here as well. So yeah, people are looking at those, but it's different for every gene. So that's the tricky part. You have to almost make the animal model first, make sure you really understand it because you want to know what you're doing, obviously, before you do that in a human. And really understand kind of how it affects that function and make sure you really know that well. And that's the challenging part because as we sit here today, there's at least 900 different genes that can cause epilepsy. So that's a lot of things to figure out from scratch. It'll get there, but that's the challenge. Yeah, go ahead. Yeah, great question. So in the past, if we did an MRI and it showed what I would call a structural change already, so there was a stroke that maybe happened in utero or during delivery that no one knew about, or a structural change just in how the brain was formed, we said, aha, that's what caused your epilepsy. I'm kind of done, I don't need to do any more. What we've learned in the modern era is many of those also have genetic causes as well. Now, the challenge is some of the genetic causes are only seen in the tissue in the brain itself, which obviously I can't go after to analyze usually. Sometimes those same genetic causes show up in the blood or saliva where I can test. But we're learning more and more that they can have genetic causes to go after. And the other thing is even the ones that you say, okay, they really don't have a genetic cause. I'll use your example, a stroke. And it had affected the temporal lobe and they have bad seizures. There's actually now people are looking to say like, okay, well, if they missed part of their temporal lobe, then the normal pathways that should have kept them from having seizures aren't there. And can we genetically modify the pathways they have to make them more resistant to seizures so you don't take medicine every day? And those actually treatments are just starting this year to look at that. And if those turn out positive, then it may be that those folks don't end up going to epilepsy surgery anymore because, if you had a choice between injection or having part of your brain removed, what would you rather do? Most of us need all of our brain. Yeah. Let me get this one. Mm-hmm. Yeah. Yeah. Yeah, great questions about the genetics. So historically, the genetic information was kind of proprietary, if you will. I mean, I might have my patients I looked at, but I wouldn't share it with you if you were in Denmark or something because, heaven forbid, we do that. But in the modern world, people have realized that, like, yeah, that doesn't work. It's not in the best interest of everybody. So there actually are now common genetic databases that are shared between the countries that have agreed to accepted confidentiality standards. As you might guess, there are some countries, without naming any, like China, that do not care about confidentiality standards, so they're not part of this, but many, we think of westernized countries, have become more and more part of this to help push that along. So great question, but that's absolutely what needed to happen. And that's just been the last few years where those databases, and more countries are coming into those that, are willing to be confidential. Yeah, and to use the data appropriately and not for other means. Yeah. Go ahead. Mm-hmm. Mm-hmm. Right. 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 Yeah, so this is another, so I don't know if everybody heard her question, but it maybe not necessarily tied in genetics, but I'll give you an answer. But why some of our seizure medications are controlled substances in that category, kind of like, narcotics or heroin or you name it, and why some are not controlled. So again, this goes back to the FDA. Years ago, Most of our medicines were not controlled. They all caused sedation, so no one worried about it. And then we said, gosh, we need medicines that don't cause sedation, and companies developed them. And then the FDA got concerned down the road that, oh, these might actually make people feel good. We should be worried about that. Someone will want to abuse them. So nowadays, the standard for all of our anti-seizure medications for actually a decade now is they have to be tested in polydrug abusers. So you pull people off the street that are abusing drugs regularly, and you tell them, okay, I'm either going to give you, the sugar water placebo, or I'm going to give you the test drug, so say lacosamide in this case, in a high dose, or I'm going to give you some other drug that we know people like to abuse. And you do a rating scale, and you don't know which one you're getting, and tell me how you feel afterwards. And if they say, oh, you know what, the lacosamide, I like that, I would take it again, they could be abused, so it becomes controlled. That's the system that our government's using currently. Right. It's maddening. No, I agree. It's maddening. I suspect, short of congressional level changes tied into the FDA, that probably won't change, to tell you the truth. But we'll see. With not to get too much into politics, but with new administration and potential new people being involved, we'll see. But it's almost one that's legislative. Yeah. Other questions? Sorry, go ahead.
Could you repeat what you said about the FDA? I know you said they listen to families, not doctors.
Right.
That's just with they're used to treating symptoms, but not what was it?
So, I mean, the traditional kind of anti-seizure medicines are almost, easier for the FDA, if you will, because they're used to regular medicines, and the companies can go in and say, you know what, we gave these to people, and they didn't know if they were getting our new drug or kind of the sugar pill placebo. The new drug, worked better than the sugar pill, so therefore it helps seizures, and, didn't really hurt anybody. And so the FDA is used to that concept for approval. When you go back to actually treating the disease and saying, we're going to fix the disease, they struggle with that a lot more. And how, because they're used to dealing with, medicine you take by mouth to treat the symptom, not like, we're actually trying to fix the problem. And we're looking at these other endpoints, not just seizures. We're looking at lots of other, things that are just as important as well. Because this is a new area to them, as well. And so they're really, I think, in my view, keep in mind, struggling with that. Make sure that's clear. Go ahead.
Is there a database where we can find if diseases, DABA or ASO?
Yeah, the best thing I would say is, keep in touch with the lay organizations that tie into, whatever genetically based disease that your loved one has, because they're all over staying on top of this. They're your best advocate, and for the most part, they know which ones are either about to be in trials or which ones, have animal models and are going to go to trials in a year. They're very on top of this. Yeah. Yeah. Go ahead. Yeah, so that's what I said. The key is you have to get, obviously, the genetically based treatment to the brain, right? So that's why these are not, as we sit here today, not taken by mouth. Now, people are even looking at that, therapies that may be able to be given by mouth and actually go through the bloodstream and actually get uptaken into the brain. But as we sit here today, we don't have any of those. We may, even though it sounds futuristic. So the only way you can do it today is actually inject it into the spinal fluid that's bathing the brain. So it's a procedure to get there. And then once it's in that fluid, the brain will uptake it itself, just like it does other nutrients from that fluid. But it has to get there as we sit here today. Yeah. All right, maybe we have time for one more. You guys have been very patient. Or maybe not. All right, thanks very much, guys. Hope that was helpful.